Hi everybody and welcome to this month's ePrescribing Masterclass. I'm Amna Patel and this is my colleague Hoyan, and we are the Chief Pharmaceutical Officers Clinical Fellows at NHS England. So these monthly webinars are where NHS organisations share their experiences of digital transformation to help support others. Just a few housekeeping. There's a question and answer box on the side of the screen which you should all put your questions into. Throughout the presentation. There will be an opportunity at the end of each presentation for questions to be answered by the presenters. We've got two presenters this time with us, joining us. There's Graham Hall and Geordie, who was speaking on two different themes. So I'll first start with Graham. Graham is the Associate Chief Pharmacist and Chief Pharmacy Information Officer at the University of Hospitals of Leicester. Just a bit of background about Graham. So he was first registered in 1985, working in the acute hospital sector for his career so far, and he's had many roles in dispensary management and aseptic services. However, clinical services are where he spent the majority of his time and was Deputy Chief Pharmacist Clinical Services at the University of Leicester for over 10 years. In 2016, Graham moved into the role of Chief Pharmacy Information Officer, which was the first post of its time in the UK, and the focus has been on the e-hospital programme and the delivery of interoperability between medicine-related systems such as ePMA and pharmacy systems. And he's been a member of the UK CPA General Committee in the role of Professional Secretary and Vice Chair. He was elected to the Council of the RPSGB and sat on the Transitional Committee as the RPS and GPHC were formed. And just a bit of outside of work enjoyment, Graham likes football and following Newcastle United. He's joined by his colleague David, who is a lead pharmacy specialist medicine at the University Hospitals of Leicester, and his colleague Deepa, who will be answering some of the questions in the chat box. Graham's presentation is on using real-time data from Nerve Centre ePMA to improve efficiency and effectiveness of pharmacy services. So I'll pass over to Graham and his team. Can you have the next slide, please?
Thanks, Amna. Good afternoon, everybody, and thanks for this opportunity to present to you about some of the work that we're doing in Leicester. We want to do a slightly different sort of presentation to perhaps the other topics that have been covered on these masterclasses, and just tell you a bit about how we've been using one of the functions of or facilities of Nerve Centre, which is our EPR, using the real-time data functionality to help direct clinical services predominantly, and some of the benefits that we've seen from that. Could you just move the slide forward, Amna, please? Sorry, the other way. Yeah, thanks. Okay, so first of all, just the things I'm going to run through. Just want to give you a little bit of context about where we are with the with our deployment of Nerve Centre and how we're proceeding with that. Then David's going to take over and talk about some of the real-time data tools, and we've just listed this, the names of those tools that are available within Nerve Centre, and David will run through how him and his team use those particularly to help things, and then I'll follow up at the end just with a bit of the benefits that we've seen. So if we could just see the next slide, please. Just a bit of context about the hospital that we're working in. For those of you who don't know, the University Hospitals of Leicester, obviously it's in Leicester, it's a very central England trust. We're a acute teaching hospital with about 2,000 beds. That's split over 3 sites. We have 17,000 staff. So, for example, in a month with our deployment of Nerve Centre, we'd probably have about 12,000 staff in a month sort of having separate logins, and with all of the different modules of Nerve Centre, we'd probably be seeing 100 million individual entries into the Nerve Centre system in a month. About 380,000 prescriptions would be generated per month. Some of the other stats that you can see on the right there also shows, you know, some of the other things that the hospital is you know, achieves in a month, which is so you can see we're an extremely busy hospital. We have a lot of vacancies within staff groups across the hospital, and particularly in pharmacy. So this is why we really want to try and use the technology that we've got and the information that we can get out of the nerve centre system to help streamline and move our services forward, and that'll really be the focus today. Leicester signed a contract for EPR deployment. We call it the hospital programme. In 2019 with Nerve Centre, we were the first people to, or the first hospital to have a contract with Nerve Centre. It was signed as a 10-year developmental contract because Nerve Centre wasn't a complete EPR, so we are developing it as we go along. It was an initial 3-year programme, and EPMA, which we happen to call eMeds in Leicester because it fits with our sort of branding of the e-hospital programme. That was one of the first main developments and deployments. The hospital is targeting an MRAM 6 level, hopefully at the end of that 3-year programme, and then to develop moving forward. And we did receive monies from the Wave 1 digital aspirant money to help us fund the trust, fund the EPR development. Could I have the next slide, please? So this just summarises where we've been really travelling from December when the project kicked off. So it's been a phased approach to the development of different modules as they become available within EPR, within the Nerve Centre EPR. From a ePrescribing perspective, the first thing was for us to move from our legacy system, which was MedChart, which I'm sure a number of you will be familiar with, and to move from that to Nerve Centre. And then since then we've been looking at those areas which where we've been using paper drug charts to move away from that. So places like ITU, we're busy doing some work within paediatrics at the minute, but you can see we probably one of those areas that we didn't get into electronic prescribing with MedChart was indeed the emergency department, which went live last September. So we now have all of our adult areas live on the EPMA system, and we've deployed across a couple of our ICUs. So we've moved into that critical care environment, and we're moving towards a paediatric deployment, probably in the first quarter of next year across the Children's Hospital. Okay, if you could just move to the next slide, please. Yeah, so that's a little bit of context and background. I'll hand over to David now to just run through, you know, how we use some of those tools. Thanks, David.
Thanks, Graham. I'm David Kearney. I'm lead pharmacist specialist medicine, and we've been using Nerve Centre eMeds for a few years now. And Graham's asked me to just sort of give us my experience. I'm not part of the eMeds team, but I'm just a user leading on one of the services that's prescribes a lot of medications. So we wanted to just highlight how we use the real-time reporting and data extraction tools that we have within Nerve Centre, and we use these to drive patient care and to use that improve our services. And we have two main tools. We'll just give you an overview and just an oversight of what the tools are and the examples of how we use them. And we're really sort of hoping that we'll be answering a lot of questions and seeing what people think of what we're doing and any ideas you've got, and we can help you as well. So we've got Smart Lists, which are a configurable tool that's in Nerve Centre. They pull on the live data points within the system. And what's really beneficial is that you can do in the system, you can do a trust-wide smart list, which is then accessible by all users within the trust to view selected information. It creates selected patient lists, But what's really powerful, what we found, is the individually configurable use of smart lists. So you can use any data points within the system to generate a list. And from a pharmacy perspective, we really use that, focusing on medication data points, but also linking it in with clinical and the operational data points as well. So we've got length of stay, we have clinical flags about specific disease conditions, we have early warning scores built in there, or observations and laboratory markers, and we've got lots of medication flags as well as things like TTOs, medication orders, drug history flags as well. And we can almost drag and drop those. I've got a couple of screenshots and the sort of data that we have coming up, and we use these to prioritize workload. We use them to identify high-risk patients, to target reviews for teams. So we have in-reach teams, all looking at sequins. We've got very limited capacity at the moment with staffing issues and increased demand. So then we use it to try and target the workforce that we have on the patients that need the most input. And we also use them for supply issues as well. Next slide, please. So examples of the smart list that we use sort of on a day-to-day basis. For capacity and demand, we've got really like the basic things that we have around medication orders, and they're sorted for medication orders that have been awaiting approval by a pharmacist, or we've got dispensary medication orders, which are orders that have been approved by a pharmacist and therefore ready for dispensing. So they just filter through. So at any one point, we can view the entire system to see all the patient orders across all beds, or we could filter them by a ward, a clinical area, clinical specialty, or a site. We do the same with TTOs, and we can map TTOs to different stages, whether they're written, we're waiting a pharmacist input, whether they're waiting dispensing, whether they've been dispensed and they're waiting a nurse check. And we can also link those then to patient journeys as well. We can link them to simple discharges, or pathway 1, pathways 2, and CMGs, our directorates. Medication with reconciliation status, again, we filter that by wards, directorates, but also we can link them to length of stay as well. So on a weekend, we can see who's been waiting the longest, and we can also link medication reconciliation, length of stay, and clinical data as well. So we can see that patients have got certain critical conditions and an increased length of stay, that we can target those as the priority, like particularly on a Monday morning, to start get on top of their medicines reconciliation, rather than just working the traditional way of seeing who's not had one, who's new from the weekend or new from yesterday. And also patients that are waiting medication review by a pharmacist as well. And the key benefits that we have are really that the intelligence in the system, it's real time, it's linked, it's all the different aspects of the patient and their characteristics that are held within our EPR are all tied together, and you can extract the ones that are appropriate for the user or the team or the trust as a whole. So we look at high-risk medications, things like we've got the antimicrobials team can target restricted antibiotics, certain antibiotics, or IV versus oral. Target those that have got are still on an IV, but their early warning score is 0, or are taking other medications orally. We can look at anticoagulation lists. We can see whether patients are on insulin, and the diabetes team can look at those. We've had incidents with things like desmopressin in the past, so our endocrine team can review all the patients who are admitted on desmopressin. We have in-reach teams that use smart lists. So back before we had nerve centre eMeds, it was reliant on proactive referrals. So you wanted the end-of-life patient reviewing, then the end-of-life referral would have to be done, and the end-of-life team would need to know where the patients were. Now they know they can just screen our whole system in real time to see every patient who's on a syringe driver. Our Parkinson's in-reach team can look at every patient who's got a disease flag of Parkinson's or is prescribed a Parkinson's med and tie the two up together. Particularly those that have got a disease flag but haven't got any medications prescribed can be prioritised for urgent review by the Parkinson's team. We've got a psychiatry in-reach team who look at patients who are on antipsychotic medications that are admitted, and then see whether they've had unadmitted doses and target those. Been really useful with supply problems. There's not a day goes by at the moment without a supply problem being identified. We have parastigmine over the summer. we had Cumbria just a couple of weeks ago, and with the system we could just log straight in, and we knew immediately we had 4 patients across the trust who were currently prescribed Cumbria, so we could make sure that they were reviewed urgently, and we can have that ongoing. And like pyridostigmine, we could check each day how many patients we had on it, what doses they're on, whether the doses have increased, and we can manage our stocks accordingly. Next slide, please. So this is a screenshot of our smart list builder. This function is available to all users in the trust, and you blink down the left hand side there, there's lots of different criteria, it's all categorized into different sections around the patient demographics or the ward and clinical specialities. We've got the observations data, we've got task assessments, so all our care plans are built in there, things like our must tools or various other nursing assessments. Medications are there, and there's a list there of the sort of the filters that we can use to look at medications. Medicines reconciliation and TTOs are also in there as well. And then I've got an example there of just smart lists that we can build. So we've been focusing on paracetamol IV recently with supply problems, but also then that's driven and more intelligence on awareness of inappropriate prescribing or use of IV paracetamol, it carrying on when it's not needed. So, and we can drill right down there. So the example I've got there is patient admitted, yes, they're at our LRI campus, they're under one of our specialist medicine teams on a particular ward, and then from that I can then see who's on VTM paracetamol and who's on that with a prescribed IV route. That will then give me a list of all the patients who meet those criteria, rather than having to go through drug charts manually or ask staff to proactively highlight patients. We can then look at them, see if it's appropriate, and then make targeted interventions accordingly. Next slide. Just another example there as well, just to sort of show the clinical sides as well. So that's, again, we've got the clinical note in the data fields there with a note of Parkinson's, and we can add there for Parkinson's medications. So we can build lists that are dependent on an individual VTM, a medication type, a BNF class, and also link that to our clinical notes. At the moment, one of our limitations is our clinical notes added manually, but we are in the process of rolling SNOMED out across the trust, and once that's fully up and running, we'll be able to use SNOMED codes built to link in with our medication reviews as well. Next slide, please. Just how do they loop to the user? So we've got lots of, we get screens when we'll go into our patient lists, just list every smart list in the trust. So the smart list may just be our campus ward whole patient list, the traditional kind of every patient on the ward from bed 1 to bed 28, or you can give them titles, and we give them titles that try and drill down to make them identifiable for users, and we can also do those individually as well. So you put your own name and you do your own list as well. One limitation is either smart lists aren't shareable, so they're either built trust-wide or they're built on an individual user level. So we do have smart lists that are used by multiple people, but they have to be just built by each individual user at the moment. But that's the development that we're hoping will improve in the future. And I've got one of our comments there from one of our pharmacists about how easy it is to, like, smart lists have revolutionized the way that we work. They've had a massive impact on us being able to use stuff to target patients much more proactively with our limited resources, and we can just see exactly which patients we need to see or which patients we need to see in which priority by using the data within the system. Next slide. The other thing we have are live flows. These are visual representations that bring together multiple smart lists. Again, you can see there's got criteria down the left. This is our TTO workflow, our TTO live flow. This again is accessible to every member of the trust who's got access to our nerve center system. We have a home today status where the ward set a home today criteria for the patient, whether they're going today, yes, maybe, or they're going home tomorrow. And then our TTOs, our discharge letters, are all built in as data points there. And each of those numbers in the box is the number of patients in our organisation who meet those two relevant criteria. So for that example there, you can see that our home today, we've got 85 who are confirmed, 9 are sat sent to pharmacy, waiting a pharmacy review, 19 are in dispensary, 13 are dispensed. If you were to click on any of those numbers, it then will give you an individual smart list. Next slide. And here's an example of what a smart list looks like once you've defined your parameters either by Smart List Builder, you've accessed it through one of our trust-wide ones, or you've accessed it through one of our live flows. It then gives you a list with all the patients that meet that criteria. So if you're a pharmacist covering multiple wards for the day, rather than having to just work through your written handovers from colleagues yesterday, or the reliance on doctor and nurse identifying patients or being aware of who might have been admitted since yesterday, we can do all that ourselves. So this would then be a smart list for a patient who meets such criteria. If I want to see who a patient who is on such a drug who's been in for more than 48 hours, it would then give me the list of the 2 patients, for example, who meet that criteria. Next slide. We've also got pharmacy reporting pages. One of the only limitation that I think we really have with Smart List is that it's purely driven on live data. So once a patient no longer meets that criteria, so it was a patient who is on a drug that hasn't been reviewed, once it's been reviewed, they've then disappeared from that Smart List. And you can't see retrospectively from Smart Lists and live flows. What we do have within our system is a limited reporting pages, and they've got examples there of the types of things that we can, all individual users, without putting data requests in or going through our data warehouse, can generate simple reports of actions or data points within Nerve Center. Next slide. In terms of like the future, obviously we've been really blessed, I think, with the use of Smart Lists and the availability of it. It's helped to drive our changes, but the next steps are we're looking at a ward service on the page and ward on the page. So this is our draft example of a live flow. Each one of these boxes will be a smart list generated to show me as a service leader everything in ESM that we think is a priority for pharmacy intervention at any one time. Nerve Center are working with us to do the mapping and do all the logistics behind generating this level of real-time live information, and from this we'll have a dashboard which will show me exactly which wards are which patients who require medication history, supplies, TTOs, who are on critical meds, who've got critical meds not reviewed, who've got things that we've asked the doctors to review the day before that haven't yet been done, all there visually, and click on that will then give me the individual patients that we can then target. So this is a service level one with all the wards. On the next slide. It's a ward-based individual ward, so if you're covering a ward for the day, it's a more abbreviated version, but it's really trying to target down that limited resource we have in the time to the most potentially beneficial patient interactions from our pharmacy team. Next slide. I'll hand over back to Graham.
Thanks, David. And I'm just going to cover very quickly the last couple of slides because I'm aware that we're a bit short of time, but by all means carry on with your questions. The team's just trying to sort of answer those as we go along. So thanks for that, David. Hopefully you can see that we've tried to exploit the functionality that's available within Nerve Center to help drive improvements in efficiency as much as we can within pharmacy, but also across other areas. And this slide here, we've just listed some of the benefits that we've identified as part of our benefit realization program. For example, using smart lists to increase the visibility of medicines orders has reduced the turnaround time on medicines being seen that they're required and authorized through for processing, by improved by a long ways from the old system. David mentioned about antibiotics and anticoagulation lists. We've got quotes there from our anticoagulation nurses whose team's been cut back to about 3. I think we've got really quite a small group of nurses now, but they're able to monitor in real time every patient who comes in on warfarin or one of the other Cumbras, and indeed the antimicrobial stewardship team, our lead pharmacist is really really been impressed with the way that you can use the smart list to identify patients on antibiotics, check things out, and I believe it saved, I think she estimates about 80 hours a year. You know, just being able to identify patients and acting on that. David showed you the TTO process life flow. There's a comment there from one of our Deputy Chief Operating Officers that live flow is used every day on the tactical command meetings as part of operational command to help identify where there's blockages in terms of getting patients out of the hospital from a TTO perspective. So that's been really good. Next slide, please. So hopefully what we've been able to show you today is how we've utilised the information that we have at hand. We're obviously still fairly new at this, and Nerve Centre is developing all the time, so we want to, well, David showed the dashboards that we're looking to develop for pharmacy, and I know other areas of the hospital are looking exactly the same, but what we're looking to do is to look at those, you know, to benefit from the bespoke real-time user-led data that is available. What we found is that they're quick and easy to create. All pharmacists can and technicians can create a smart list, which only they would see. The eMeds team can create smart lists that is visible for groups of staff or indeed all staff. We found that they've got a high impact in the visual display, speeded up decision making within our department. They have allowed senior pharmacists like David's to target resources appropriately, and we believe they've improved patient care and safety and improved increased productivity, and these are things that we're looking at how we can measure and sort of, you know, be able to show that from data. But I shall leave it there because I'm aware we're running out of time. Thank you very much. Oh, back over to you, Anna.
Oh, sorry, Lynn.
Oh yeah, there's contact details for David and me if you wanted to contact us and any other questions after the webinar. Thanks.
Thank you to Graham and David and Deepa. It was a really interesting presentation. There's been a lot of questions in the chat box, but I don't think we're going to have time to answer all of the questions. Usually we'd have a bit of a Q&A at the end, but I'm just conscious of the time. Can I ask just one question from the chat, which is, have you been able to redefine your clinical service using the real-time data?
Sorry, how do you mean sort of redefined?
It was a question, looks like from Anna, who said, have you been able to redefine the clinical service using the real-time data that the system obviously outputs? I don't know whether this is to do with workflow or work processes or skill mix.
Well, I think what I don't think we've used it in such a sort of a high level way to sort of redefine things. I mean, we're using it more reactively at the minute. I mean, I must admit, to be honest, a lot of the times what we're doing at the minute is firefighting, which many departments are like this. But I think, you know, as we've deployed the system and we get it, the system, as I mentioned, it's across all adult wards. Once we get it in children's hospital as well, we'll be able to, you know, take a step back with the lead pharmacist and the clinical services deputy chief pharmacist to perhaps then have a look at the, you know, the whole of the profiling of staff, how we operate, you know, whether we operate traditional models where everybody visits wards every day, or whether we, you know, do things where we can, you know, maybe we have a central team that is looking at Nerve Centre and then, you know, sending out teams of people to sort of target difficult patients. So at the minute we're doing that on a bit more of an ad hoc basis and just trying to utilize what resources we've got in the most efficient way to deal with things. But certainly that's what we'll be planning to do in the longer term.
Yeah, that's great, and thank you. And I don't know if Deepa is going to stay on to answer some of the questions whilst we've got the next presenter, or whether all the questions will be put on the future platform page. But yeah, if Deepa and yourselves could maybe stay on just to answer them questions.
We will. While Jodie's talking, we'll get on and try and answer these questions as best we can. And if anybody wants to ask us separately or follow up, then just get in touch. Yeah.
Yeah, it's been
Thanks.
really insightful. Thank you.
Thank you.
I'll pass over to Helian now.
Thank you, David, and thank you, Graham, for your presentation. Thanks for the audience for engaging and asking very interesting questions. So it's a pleasure for me to introduce to you Jordi Said Dominguez. Hi, Jordi.
Hello, hi everyone.
Yeah, so we had a catch up earlier this week, and it was interesting to see for me some commonality between Jordi and myself. So we both qualified overseas. We worked abroad before we moved into the NHS, and also we both ended up kind of in the digital space. So a bit about Jordi then. He qualified in Barcelona and worked there for a little bit before he moved on to become a mental health pharmacist at Merseyside Mental Health Care Trust. In 2009, he moved on to the World University Teaching Hospital and became an electronic prescribing pharmacist. And I think that's where he kind of became really interested in a digital work around being a pharmacist. He'd done some great work there, including migration of the old EPMA system to the product that they're using currently, which is Cerner product. That happened in 2014. After that, he obviously worked on other projects within that, deployment in A&E, deployment in the theatres as well. His current job role is the clinical system development team leader, at Alder Hey Children's Hospital. And let's me have a look. What he's done there, he's done projects leading on implementation of closed loop medicine administration, dose range checks, amongst other projects. And his hard work ultimately led the organization to obtain the HIMSS level 7 status in 2021 in the midst of the pandemic. So Alder Hey became the first pediatric hospital in Europe to achieve this award. Jordi today is presenting on the implementation of Meditech Expands at his trust. They went live in September this year, and he'll be presenting in particular on the benefits that brings to medication reconciliation and discharge medication. So Jordi, over to you.
Okay, thank you, Hojan. Thank you very much. And impressive numbers for Graham. You know, like the number of the hospitals and bed numbers that they implement is quite impressive. We are a very small pediatric hospital in Liverpool, so our numbers are not so big, but yeah. That's cool. So I'm going to explain mainly like our role in Expands, but it's mainly focusing in medicine reconciliation. So I'm going to focus in medicine reconciliation in this talk. So yeah, if we go to the next slide, please. Okay, as I say, we will go Meditech Expands. So our hospital, Alder Hey Hospital, is a specialist pediatric hospital. So we've got only children, okay? We don't have maternity or SCABU. We've got a little neonatal unit, and there's an appeal now. So if you want to contribute to the funding, we are like a primary, secondary, and tertiary care supraregional center, and we do lots of cardiac surgery. So when there's a neonate that needs cardiac surgery, they send them our way, and then we need to send them back to the SCABU unit. So we are like trying to build a SCABU unit in the hospital itself. But at the moment, we don't have maternity, we don't have a SCABU. So we are like a big hospital that we got children all over the area, North Wales, Isle of Man, Lancashire. And every year we care for over 270,000 children and their families, okay? Our bed numbers are very, very small. We've got only 250 beds, but we've got like a massive outpatient unit. And then EPMA was implemented before I arrived. The PMA that they use is Meditech and was implemented in June 2015. Interestingly, it was implemented like 2 months before they moved to a brand new hospital that was built like in the park. So we've got like great facilities in Liverpool for Alder Hey. So yeah, I invite you to come. So what I'm gonna focus mainly is like we've been with Meditech for a while. I came like 5-6 years ago and Meditech was fully implemented, but we were like in the old version. So we've been working for the last 2 or 3 years to move to the new version, which is Expands. And thankfully we implemented that in September 2023. The version of Expands is mainly web-based. So Meditech was really like desktop-based, like all looking, and now the new version is quite like web-orientated. So that's what it is. So next slide, please. So I'm going to focus in medicine reconciliation, okay? Looking in Google about this presentation is like, what is the description of medicine reconciliation? And nice guidelines that they've got a very nice description, you know, like is like you need to identify an accurate list of all the medications that the patient is in, okay? And you can check the medication that is brought to the hospital by the patient. You can check the GP surgery patient records. You can check the repeated slips if they bring them. You can check case notes, community pharmacy, like all the sources of information that you've got just to create a list of information that will have all the name, dosage and frequency and route of administration of the medicines, okay? All the discrepancies should be identified and any changes documented. So the result is a complete list of medications, and that's what we do. Okay, I would say like that's a big part of the job of the near patient team. So I'm sure that in all your hospitals, probably your technicians or your pharmacists, they spend a big time of the day just trying to do like med regs, and there's this big push to have like med regs in 24 hours. Then because the weekend is in there, sometimes it's 48, 72 hours. So there's a big push just to have a medicine reconciliation for every single patient that gets admitted in the hospital. So it's the same case for us. Okay. Next slide, please. Okay, so as I say, the most important thing of medicine reconciliation is almost like how to get a list of medicines, okay? So when I came in here like 5-6 years ago, all the pharmacies were using what is called the NHS Summary Care Record. I just Googled that yesterday and I realized that it's been changed to National Care Record, so they've changed the branding and the name, but it's still in there, okay? That was a little bit challenging, okay, because you need a smart card. You need to find a computer with a smart card reader. You have to put the smart card. You have to launch the Summary Care Record. You have to look for your patient. You have to find your medication list, and then finally transcribe it to Meditech. So it was good, better than before. That I'm old, so we were faxing prescriptions like years ago and so on, but it's still not the best. So a few years ago, like before COVID, we implemented like almost like our local record. It's like called Share to Care, and it's the motto is like the data saves lives. So it's like a big initiative, so to have like a local, like almost like place to look for information. So we've got like a Merseyside and Cheshire platform, which is Exchange. And that's much better because the patient, you can launch the patient on patient context from Meditech. You don't need your smart card, and you can have access to all the information in there. Okay, so it's just only for all these patients that they are in there. You can have access to primary care and see all the meds in there. So that's where we are currently with Share to Care, and our aim is just to get GP Connect working. So I'll try to speak to explain really what is GP Connect in a bit. Okay. So next slide, please. So that's the Share to Care, is the e-exchange platform that we say. So when you're in Meditech, you've got the patient, just only click a link. We've got single sign-on, so you are automatically log in. And then in here, you can see that all the hospitals in the area, they share like letters and discharge letters. So that's our local record, and it's very interesting, especially because we've got lots of like outliers from maybe the Wirral, maybe from Omskirk. So they come, they because we're a specialist center, and then sometimes the best way to access all the information is with this local record, okay? So we've got access in here to the Cheshire Care Record. If you see in there where it says primary care, you click in primary care, and it's not the Summary Care Record, but it comes like a EMIS web viewer, which sells you almost like all the information of the regular medication that the patient is on. So that's how we check things. We are like planning to integrate, I think that's been ongoing for years, to Lancashire and South Cumbria. So if that's successful, we've got like a big pool of almost like 4.2 million people records that we could access. So it's a great platform, you know, to check our patients. Cool. Next slide, please. Okay, and what we are moving towards is like GP Connect. Okay, what is GP Connect? It's almost like the step forward. It's almost like an API. Okay, so all the GP systems, they fit almost like to this GP Connect. And this GP Connect is almost like the National Care Record, and then our main supplier, which is Meditech, will pull the information from it. Okay. And this GP Connect is as well available. It's like as an API to query medication, and you can have medication lists. So there's like a plan maybe is in development, maybe to have like GP Connect consumers, maybe patients, to access their own record and their own medication lists and other stuff. I took this from NHS England, so sorry if there's copyright of it. So yeah. So if we go to the next slide, okay. So that's how GP Connect will work. We are still not live with this. So it's almost like you see at the bottom that says like external medication history. So you click like query GP Connect, and what happens is like rather than the information coming as a list or as a text that you can check and then need to transcribe, it comes like in drug context. So like the MP, the BMP. So the system is able to read the medication, and it comes like with a map to our medication. So it's as easy as just only, and it doesn't go directly to the record. It's very important to say like it's too risky, to go directly. It goes to this holding section. You click on it, 10 seconds, you'll get it in there, and then you can select which ones to add to the patient. So you click add to the patient, and that will go to the GP, to the patient records. Okay. So it takes a few seconds, and then we migrate. So if we go to next slide, please. Okay, so this is Meditech Expanse. It's very interesting. We are like almost like web-based, but there's still a few functionality that is still in the old platform. So all our prescribing, all our TTOs, everything is in web, but the home meds are still in the old platform. So you need to almost like go back and forth to see what it is. So we've got the home meds tab in there, and then you need to click in the home meds. I want to reassure you that it's not only the pharmacist's job to do the medrec. It's like the doctors, they need to do as well medrec. So we are trying to get all the prescribers always to get into the habit of, the patient gets admitted, you click them in, check the home meds and check what's in there. Okay, go to the records, share to care, and then bring the information. As I'm saying this, is like we are a tertiary center, so as much as we are very advanced and we can get a list of medications, we still got like patients from the Isle of Man or from North Wales, and we still rely on phoning the GP and says like, what's the medication list? So it's great, but I think the national care record or our records are quite local, so you've got always like the handicap of these patients. Next slide, please. Okay, so this is the Meditech Expanse home meds, and as you can see in there, before all the home meds, they were like in a dictionary, what is called Meditech. Some people they call it drug catalog, some people they call it databases. So now it's not a drug base anymore. It's like an API to the FDB. FDB is First Data Bank, and it's like our clinical content provider. So in there you can see everything that is in the UK market. Okay. So that's the challenge. So all of a sudden, when you try to document home meds, and because this GP Connect is going to come, you've got the whole UK catalog of drugs that they are in the system. So that's quite risky, and that's why we introduced this formulary-only tab, as you can see in there. So next slide, please. So as you can see, like if you untick it, you can see how many ibuprofens we've got, and then it was like almost like impossible to document things. So we've got this tick that is like, although we've got like access to the API to the whole UK market, we can filter and we can see only the medications that they are like in our formulary. In Liverpool, our formulary is joint, is in a joint account, so we don't have like an Alder Hey hospital as such. We've called it like Pan Mersey formulary, and the formulary is like almost what everyone is. So the fact to have this flag, it takes lots of noise from the system. So like maybe there's like 30, 40 ibuprofens in the market, we won't have them all. Okay, so that's why the development of this flag has been like a key part of the success. So next slide, please. As you see, like you document the meds, you find them, and as well you put them all in there. Okay, you put all the details of the drug as usual, and I say like very interesting. Graham and Dave could do lists of who's done like the medrec or not. We can do them as well somehow, and then once you finish the medrec and you are happy with the medication, I didn't provide a screenshot, but there's a pharmacy assessment tab that you can see in there, and you just only say that you've done the pharmacy assessment. You say the person that has done it, and a few other questions that asks you. So that's how we document home meds. Okay, and now we'll go back to Expanse. So the home meds are still in the old version, but to be honest, it flicks between one and the other one. So if we go to the next slide. So you see, like now you see all the home medications in the left hand side. Okay, and that's how Meditech Expanse works. So you can just only like pass them and reconcile the medication, and reconcile them to the inpatient. Okay, every product has got flags. Okay, so if you document like a product that we don't keep and is like at AMP level, it will go to our generic. But as well, some products I know that they are like brand specific, and in these cases that they are brand specific, we'll keep the brand. If something is not formulary, we still allow you to document the home meds, but when you move it to inpatient, it's gonna say like it's non-formulary. And it's going to still keep all the interaction checks and the dose range checks, because the information now is in there from the home meds. So it's as easy as selecting every medication and decide if you want to carry on or not. So if we click to the next slide. So you can see in there the beclomethasone, we've done it. The patient got admitted today. The ibuprofen, he's having like a little bit of asthma attack, so he's been on hold, okay? The multivitamins are okay, and the salbutamol has been increased. He was taking 2 puffs, and now he's taking 5. As you can see, it goes yellow, and you can see like the big difference in there. Next slide, please. And then once you've done the reconciliation, you've got all your inpatient meds that they are in there, and then you can prescribe a new med. So for example, in here, we prescribed some amoxicillin for 7 days. So the patient came in, we keep with the inhalers, we've increased one of the inhalers, and we put like an antibiotic for 7 days, and we've put all the ibuprofen on hold, okay? So that's what we've done the medication. In the right-hand side, you can see the home meds widget, which says slightly the medication, but as soon as you click in the widget, the old Meditech will bring the list, and you can see all the information in there, okay? So next slide, please. I think, yay. So, okay. So we finish all what we call like medicine reconciliation or the start of the process. You know, like that's almost the most important. Is like you've got your home meds, you reconcile them to inpatient, and then you administer them in the MAR, and then closed loop and all the sorts. But a key important piece of medicine reconciliation as well is discharge, okay? And discharge letters. And discharge letter standards are very interesting. So the NHS England contract has got like a very clear guidance on what the discharge letter should have. I'm sure that all of you've worked through this. So the discharge medication item needs to have always the medication name, the form, the quantity, the method, those directions, those timings, the structured dose, additional instructions, course details. So that's everything in there. But interestingly as well, the discharge letter standards, they say that you need to include a medication changes summary and the medications that they've been discontinued. I don't know how you're doing this into your systems. Until the introduction of Expanse, really, the only thing we were including in the discharge letter is just only a list of your medication, okay? And it's like the medication on discharge, okay? And then we put like a little text at the bottom for prescribers, and we say like, oh, you put in there like if you stop anything or if you've done any change, okay? That was counting, and we were like compliant with the discharge letter standards, but it wasn't great, and the information was sometimes missing. So it wasn't the greatest of the opportunities. Some doctors, they were great at keeping all the information and always like trying to put everything in there. But sometimes some patients had something stopped, and then we then sent an information in this free text box. So Expanse has improved that massively. So our discharge letter is not only the MedRec in admission, the MedRec on discharge is improving quite a bit. So if we go to the next slide. So you see now in Expanse, we've got this new discharge tab, and you can discharge the patient from there, and then you can order a TTO, okay? The discharge section is used as well for our outpatient clinics. So, you know, like it's what Meditech calls it like ambulatory orders. If you order things as orders, they are inpatients. And then if you are in discharge, you can order like TTOs, or you can order like in outpatient, like outpatient orders, okay? We do as well FP10s. So because we've got like an agreement with GPs, we prescribe almost like all the ADHD drugs for the region. So sometimes we are like working, and then we prescribe like all the medication in the outpatient clinic, and then we'll print the FP10. So it's still very old fashioned. It's like we'll prescribe it in the system, and the system prints the FP10 on paper, on green paper, but at least it's printed. We are trying to work towards EPS integration. I know that the NHS has opened that to secondary care trusts, and we are working into it, but I think it's going to take still some pain and sweat to get there. So at the moment for this talk, I'm going to focus mainly on the inpatient, not outpatient. So really, we'll go in there and we order TTOs, okay? So it's as easy if you click order TTOs, and then if you go to the next slide. Okay, so you've got this busy screen that is almost like in one column, you've got your home meds, and you call you which medication the patient was on, okay? And then on the other column, you've got everything that the patient is as an inpatient, okay? You can see that it's matching, and you can see that the salbutamol, for example, went from 2 puffs to 5 puffs, okay? The rest of the medications are still in there, okay? And then the ibuprofen has been on hold, okay? So to do the TTO, you need to navigate this screen almost, and it's like you need to go for every product and then decide if you want to continue or you want to stop, okay? So next slide. So when you click continue, every slide has got like a mandatory question, and the question is always like, is this to continue long term? Yes or not, okay? We used to call this in old Meditech GP to continue. Now we've changed it to continue. We had some problems because we've got lots of medications that they are like very specialist to the center, you know, like growth hormones, hemophilia, blood clotting factors. And then we were saying to the GP to continue, and then they were really confused because GPs didn't have access to these drugs. So we've rebranded this, and we call it like now to continue. That has created as well some challenges, but that's in there. Okay. So for example, you can see for the ibuprofen we've stopped, but for the beclomethasone, for example, we've continued the inhaler, and for the Avidec as well. So if we go to the next slide, please. Interestingly, you see the salbutamol was on 2 puffs and now is in 5. So the system is going to tell you that you've changed the dose, okay? And that's going to be informed. And then what happens, probably you'll put like some information in those instructions to say like it's to reduce gradually once the group is getting better. So that's what we do. And then for the amoxicillin, for example, because it's only a short course for 7 days, you'll click like probably like to continue now, and then it makes mandatory how many days you want in there. Okay. So as I say previously, we always like send only like a list of medications, and now there's been a massive improvement, because if we go to the next slide, please. So now the system is able to calculate what is new, what is old. So if you've got like a correct home meds and inpatients, and then the TTO is done correctly, you send almost like the information in one screen. Okay. So you're saying like, oh, the patient has been started on amoxicillin, a course of antibiotics. He was on Clenil and Avidec, and that's to continue. But the salbutamol was increased, okay? And then they stopped the ibuprofen. So that helps massively all the GPs, okay? So the GPs, rather than to have like to figure out what has been stopped, what has been continued, what is not, they've got access to all this information in the system. So if we click the next slide. Okay, so that's a discharge letter. I couldn't get a discharge letter of this patient because we have to put it through the engine, but really that's more or less like a standard discharge letter that we've got. So if you see the table that says medication at discharge, that's the standard, and that's what we used to use in Meditech. We were discussing, Meditech before Expanse. We were discussing if to get rid of this, but I think it's still too early to do that. So what happens is like we just only put like a list of all the medication that the patient is discharged on. So, like with all the information and so on. And then at the bottom, we've got this new section that is called medication changes. And then you call it like, it's color coded, and you can see what is a stop, what is new, what is continuing, what is change. So the GPs, they've got like an extra reference. I think if you want, you can still go through your list and see what's wrong from your list. But if we've done it correctly and everything flows nicely, this is of massive importance for our primary care colleagues, that they can see in one glance, like which medication is in there. And as well as a prompt for our clinicians just to document what's been stopped or what's been and the reason. Okay, so the fact that they can see this preview when they go to Meditech and then they do the discharge letter is very interesting, because they can that's helping them to do all the information in there. So that's mainly everything. I think we've done the medicine reconciliation from home meds to inpatient, and this new thing that is like the discharge that I'm very proud of. So, and that's Meditech Expands, and that's what we've done almost in September. So if we go to next slide, I think that's the last one. No? Yeah, thank you for listening. Yeah, any questions?
Thank you, Yodi. That was really brilliant. I'm just in awe with the system that it can churn out the discharge medication, and that makes the GP's life so much easier, especially, I suppose, in pediatrics, where you have to think about, okay, what formulation you're using, what concentration, how do you administer, and things like that. There are some questions in the chat, and I don't think we'll have time to answer them all in this session. Are you happy to answer them afterwards, and then we'll post them on the future website? Would that be okay?
That's good. Yeah. Happy to do that. Yeah.
Yeah. Okay. I've got a question to ask. From Brian. When a patient is discharged and then they are readmitted, are the old home meds pulled in from previous encounters? So sometimes you have these kids that are frequent flyers. So will you see the meds reconciliation that was done maybe a week ago or a month ago? How does that work?
That's fine. Hello, Brian. It's like I used to work with him in the world. Good to see you. So I think it's like that's interesting, because we've got sometimes our medicines record is much better than the GPs. We've got like some patients that sadly they spend a big life in the hospital. Your palsy patients, your oncology patients. So sometimes the GP record is totally out of date. So for these patients, really, we don't do anything. So before in Meditech, before Expanse, the TTOs, they used to go to the home meds in a holding section, and then in the next account you could move them directly to the inpatient, sorry, to the home med section. In Expanse, this is happening automatically. So everything that is a TTO or everything that is like prescribed on outpatients and is prescribed as a regular med, and you click the GP to continue yes. Okay, you know this flag that we've set to continue yes, automatically will go to the home med record. So if the patient comes in next week, all the TTO from today will be in there for you, ready in the home meds, just only to transfer it to the inpatient. You need to be careful because maybe you know, like if it's 1 week, it's fine, but you know, like if it's like 6 months, probably it's good to go to the GP record, you know, to make sure that the patient didn't have anything from the GP. But the regular attenders, like we've got a good process of like coming back. All our renal patients, you know, the dialysis, they tend to have like a home med record, like very up to date. So.
Yeah. Okay, that is brilliant. Should we do one more? Or?
Yeah, just do one more question.
Yeah. So you mentioned a database with all the drugs in that you guys keep basically. What would happen if a patient comes in with something that isn't UK licensed, or maybe it's not formulary for you? What would happen then?
That's happening loads in children. So in children, we've got lots of unlicensed, lots of diet products. We can still add manual drug concepts, what is called, to this API of FDB. So we can do it. The problem is like if you add manual drug concepts, so what happens, like all the data is like in an external server, and the thing, there's a call. So we've got like some functionality in Meditech that allows you to put like some manual drug concepts in there for you to look. But the problem is like they don't do dose checks or they don't do allergy checks. So if you are lucky, like it's like a product that is got like a tablet and the liquid is not licensed, you can just only use the tablet maybe to do all the interaction checking or all the things. But you know, like if it's totally a product that hasn't got any information in the UK market, we are like blind, so we don't offer any kind of decision support, but we can still add them. So all license are in there. I should say that DM&D are getting much better to include all license. A few years ago, they were like a pain, nothing was in there, and now FDB and DM&D are slowly getting there. So.
Okay, I think that's thank you for the answer. I think that's what we've got time for on this session. So thank you so much for presenting today.
Thank you, everyone.
Can we have the next slide, please? So just for all listeners, your certificate will be sent out to you through the mail, and there will be a recording of the session available because we have covered quite a lot of ground. The next session will be in February the 7th. We don't have a session in January. If there's any feedback around this session, please contact Sarah. If you've got any ideas of topics that you want us to find speakers for, please contact Sarah. If you would like to speak yourself, again, please contact Sarah. Her details are on the slide. That just leaves me with thanking you all for participating. Thanks for joining us. Yeah, and I'll see you guys next year.
We'll see you in the new year.
Yeah.
Bye.
Thank you.
Have a good Christmas. Bye.
How does this?